And I'll raise some challenges and for both research and practice around this field. And then introduce an idea of urban governance and say some things about what I mean by that. And I guess the important thing is that by governance, I mean not just government. In fact, I'll argue that much of the reform right now in planning and public health has been limited to just government reform. How can we get planners to think more like public health people and public health people to think more like planners or designers or think spatially? That's necessary but insufficient, and I'll argue for what we need is a broader conception of urban governance, and then give you some examples of that and summarize some things about healthy urban governance. So just some words on urban health inequity and inequities, what I see as a global health crisis as big as any other, but often not getting as much attention. World Health Organization has put out a series of reports in the last few years, the most recent, the end of 2008. The image on your lower right there called Closing the Gap in a Generation, focusing and arguing to focus the entire energies of WHO and local health departments on health disparities, on health inequities within countries and between countries, within cities, and within communities in cities, rural and urban. But the argument goes that urbanization improves life expectancy and reduces morbidity, but still, and as the world is urbanizing, but still the urban poor have the worst health outcomes, including things like premature mortality, than any other group living anywhere else. And this is true in the global south, in developing countries. You see this urban health penalty. If you live in a slum in Nairobi, you're worse off than if you live in a rural area, and you are equally as impoverished. And we see the same thing in the United States. And what I mean by health inequities, and I borrow this definition from a number of folks who work on this area in the literature, and these reports sort of use a very similar definition of a disproportionate burden of premature death and preventable and remedial disease for the poor and communities of color. So inequities are preventable, and that's the focus of action, is that we can change these inequities, and I'll give you some information on them in a moment. But the bottom line story for the U.S. and for urban planners in the U.S. is that it doesn't matter what disease you're concerned about or if you're concerned about mortality. Infectious disease, chronic disease, at almost any stage in the life course, from an infant all the way through the elderly, that those in the worst and greatest impoverished neighborhoods, largely communities of color, often immigrant communities, have the worst outcomes of just about every measure. So the point is that a disease-specific approach is too limited because people have comorbidities, meaning they have overlapping health challenges who live in these neighborhoods. They have asthma and diabetes and maybe mental illness, and they overlap so that we take a single disease focus. We're missing the way people actually have to manage their daily lives, often in these communities, whether it's in the South Bronx or West Oakland and places where I work, or in Chicago or Boston, or in Detroit or any major city across the U.S. Just a few, some data to just support some of this, the sort of wealth of research on health disparities, particularly between racial and ethnic groups in the United States. This is information on age-adjusted heart disease death rates for African Americans and whites from 1950 to 2000. And the disturbing aspect of this line is, well, you can see on average everybody is, fewer people are dying. And that's often the good story we report. And that's a positive development, I would argue, of public health and other social policies, and improvements in medical care. But what we see is a rising gap in the disparity. And this is the disturbing part that has continued. In fact, what this trend shows, and this is data from David Williams, who's at Harvard in the Harvard School of Public Health, is that the actual black-white disparity is rising. And if we continue this trend for another 10 years, we would see that gap increase. This is age-adjusted cancer death rates, and we see a similar trend. The gap increases, begins to decrease for both, but it's still there. So in 50, 60 years, the health inequities, at least in these data between blacks and whites, we have similar information by neighborhood and by county, that disparities are on the rise. They're not, we're doing better in the aggregate, but we're not improving health disparities. And this is not just reflected in these data, but the latest Healthy People report, Healthy People 2010, I guess, one of the top 2 priorities, which is the blueprint for public health for the United States, was reduce health disparities. So federal government, local public health departments making this a priority. But what are the root causes? This is where there's sort of major disagreement on what we ought to do. We can show data and these trend lines for a long time, all kinds of indicators of morbidity and mortality, but what ought we do? Where ought we focus our energy in terms of policy? Again, that health is not primarily a function of health care, but where we live, work, and play really determines these outcomes, in my view. And that place matters for health, and it matters in a number of ways that are relevant to the work of many of you in this room, of planners, designers, architects, and others. Things like affordable housing, the extent that neighborhoods are segregated, often racial residential segregation, the opportunities for living wage, well-paying jobs with health insurance, safe and toxic-free, that should say toxic-free, not toxic environments, the levels of discrimination within a place, levels of violence, food security, how secure are people to eat and afford healthy food, and access to quality services, like public education, social welfare policies, public transportation, childcare, and of course access to primary care. But these things are driven by policies. They don't just happen on their own. They're driven by concerted efforts to make these things available or not available in particular places, to build and maintain affordable housing or safe streets, or to encourage the siting of facilities like supermarkets and libraries and other things in places. And that's the work, in my view, much of the work of urban planning and urban policy. Drives many of these opportunities in places. But so planners, and this is just sort of an overview of something called what the World Health Organization and others cite as the social determinants of health, what these sort of place-based characteristics that I just mentioned, and sort of linking them to specific health outcomes. Everybody always says, well, if you improve streets or you make the place more walkable or improve green space, how do we know you're going to get to health outcomes? So it's very difficult to make that causal chain, but there, I think, is a growing body of literature that helps make those connections from specific exposures or lack of access to certain amenities in a place and specific health outcomes. One thing we're working a lot on in the San Francisco Bay Area, New York, and actually in Europe as well, is noise pollution, which probably isn't a big issue in here, but noise pollution, big thing in cities. It's the #1 complaint that residents have in San Francisco and New York City. When they call up this, it's called a 311 number. You can complain about anything and everything. The #1 complaint is noise. So what can we do and make this a public health priority? Basic sleep deprivation all the way to issues of hypertension, loss of work time, a whole cascading effect, public health and social impacts from noise pollution. But part of the work that I've been doing and others in this area is to try to make these connections between the work of planning and urban designers and different health determinants, not necessarily always getting to health outcomes, but different determinants of well-being. And we ought to do a better job of making this case, and we need to, because until very recently, and in most places, in fact not in many public health or public planning agencies, there isn't much work on either space-based or place-based linking these determinants and health outcomes. So most planning departments that I visit don't have anybody who knows much about public health. Well, what are some challenges of trying to make this a priority of both how we train people and in practice? There are many, and I'll just highlight three here. The first is more robustly conceptualizing this relationship between place and health. And what I mean by place is really drawing from a rich literature in fields of anthropology, sociology, urban planning, architecture, and the rest, that we think about places relationally, and not static variables of having built environments and natural environments and economic environments, but think about how those things relate in a dynamic system. So places are their physical characteristics, both built and natural. Their social dynamics, their social forces and social services that we ought to consider. Of course, there's the material characteristics, economic value, and things like population levels of income. But importantly, and something that I think is often ignored in much place-based research around health, is the meanings that get attached to places. That's a safe school, or that's a safe street, that's a healthy neighborhood. How do these meanings get constructed? Who's doing that construction is often something that's overlooked in planning and place and health work. And also often overlooked, I would argue, are the public policies and political institutions that shape much of the physical built, natural, social, and material environments in places. So when I talk about thinking relationally about places, it's thinking about the interaction of these dynamics, not teasing out individual variables and trying to isolate them as drivers of certain key health outcomes, which is what a majority of health in place or planning and design and health work has done to date. And to recognize, of course, that places are constantly being constructed and reconstructed. And these meanings are contested, and they're contested over time. So how do we take into account this conflict and uncertainty in places in the way that we frame them and then sort of try to research and intervene in them? A second challenge is shifting from problem to solution analysis. And this is, again, another focus of my work. Some people call this appreciative inquiry. Public health has done a wonderful job over the last century or more, since at least its sort of emergence in modern practice in the United States, of documenting things like disparities between population groups, documenting problems. And we continue to train people in biostatistics and epidemiology and the rest to do this, and we do it pretty well. Lots of uncertainty, we challenge about what models or what statistical methods to use, but we could all agree that we see continuing trends of problems. What we don't do well in both public health, and I would argue we do a little bit better in planning possibly, is to experiment with solutions and test them and test how well they're working. And devise strategies to adjust those solutions over time if they're not working, if they're not improving, say, population health or community well-being. Too often we're focused on just this part and not how do we get from the analysis to experimenting with solutions and intervening. Everyone talks a lot about evidence-based practice, right? And so the word that, or the phrase that's been floating around in a lot of my work is practice-based evidence, practice-based evidence. How do we move and shift this work in both the way we're training people and in practice in things like health departments? And the third challenge, major challenge, is to sort of open up and democratize the science of this world. Too often it's expert-driven, not engaged with community folks, for example, or a range of disciplines. These are complex problems, obviously, that are not going to be solved by one discipline or one methodology or one analytic model alone. In some of my previous work, I've borrowed this term from folks in the field of science and technology studies to argue for this co-production of knowledge and expertise when we're trying to address these complex problems. And sort of the one example of this co-production idea is when you walk into your physician's office and you have a problem with your body. At that very moment, and hopefully there's a conversation that happens between you and your clinician, those initial questions on sort of how you're feeling, what's going on with your body, you are probably more expert than your MD or the nurse practitioner or whoever you're talking to at the moment about your illness. You know what happened to you in the last few days, what you ate, a whole bunch of things that have happened. You know about how your body normally feels or not. As that conversation progresses and as maybe some more tests are done, that clinician may be able to look at things inside your body or run tests that you may not just know intuitively based on what you feel. In fact, both forms of knowledge are forms of critical expertise for problem solving, as any good physician would tell you. In a similar way, we can think about neighborhood and community health problem solving as being critically co-produced in this way, with people who are living in places, experiencing disease and death and coping with it on a regular basis, and folks who have models and analytic perspective from other places and with other sets of skills. In fact, these are not new ideas, and none of these sort of challenges. The image on the top right there is from Hull House in Chicago, where residents and folks like Jane Addams and Florence Kelly and others began to do research with local residents on health inequities in neighborhoods across Chicago and began to document it. But also we're out in the streets, cleaning up streets and doing sort of place-based interventions. I think there's a lot we can learn from some of the work of the settlement house movement and many other things during this progressive era. And of course, policies such as urban renewal. This image in the middle is an image of the first urban renewal project in Oakland, California in the 1950s, which came out of federal government policy directives from the Federal Housing Administration in the 1940s and 1950s, really reshaped urban neighborhoods into what they now look like today. So policies and institutions matter for getting at some of these challenges. And ultimately, government reform, as I said earlier, is not going to, I think, work. What we need is to think about an idea called what I'm calling healthy urban governance, and I borrow this term also from the Healthy Cities movement around the world, which is led by the World Health Organization. And the idea is that governance is not just government, but it's the norms and routines and institutions and the evidence base that is built to generate collective action. That happens in nonprofit organizations, that happens in different kinds of coalitions, it happens in the research community, it happens across different sectors of government agencies. And it includes processes for identifying and framing new policy issues, generating new standards of evidence, which is critical in this field. We just don't have a lot of the evidence in some ways to drive and support some of these claims. It constitutes some actors as experts and others as non-experts to weigh in on these problems and generate solutions. Lots of uncertainty in the science and in the policy making. And so how do we set up processes to deal with uncertainty and different knowledge claims? How do we make this work publicly accountable and visible? Things like what's the role for the media? And how do we implement and monitor decisions and set up new networks to do this is all part, I would argue, of healthy urban governance. Let me give you a few examples from my own work of how I think these dynamics are being practiced. So I'll fly you to Brooklyn and a neighborhood called Greenpoint, Williamsburg, which has historically, it's been changing or has changed fairly rapidly over the last decade, but it was historically a very industrial neighborhood with many environmental threats, air pollution, hazardous materials. This is an image of trucks queuing up to a waste transfer station. 60% Lower Manhattan's and Brooklyn's waste moved through this neighborhood on a daily basis. It was picked up on the streets, loaded onto, and brought to these things called transfer stations where they would dump the garbage, and then most of them are open air, and they would load them onto longer haul trucks, and these longer haul trucks would drive to places like Virginia and Ohio and other places that New York City could sell off its garbage. But the resulting pollution and odors and noise from trucks, in addition to the city's largest sewage treatment plant and its only low-level radioactive waste processing facility, all in this one neighborhood, really stimulated much attention from this community that was largely Latinos and Latino immigrants, a Polish and Slavic immigrant community, and one of Brooklyn's largest Hasidic Jewish communities. And these three ethnic groups came together to form one of the first multi-ethnic environmental health coalitions in New York City to stop the siting of more of these hazardous facilities in their neighborhood. And they filed one of the first federal government environmental justice lawsuits ever in the United States. That raised the profile of their work to the federal EPA. And the EPA at the time was looking to pilot a new project called the Cumulative Exposure Project, where they were going to look at the cumulative burden in places of environmental threats. I was actually working for New York City government at the time in their Department of Environmental Protection, and the EPA called us and said, hey, we got this great new program, we'd like to pilot it somewhere. It sounds like, you know, from what we hear about this lawsuit, that there are a number of hazards in this community. Do you have any data? We said, yeah, you know, we got some data. And they said, great, can you send it to us? We want to pilot this new model in this place. So we shared the information, and these were folks in Washington, D.C. at EPA headquarters, and 6 months later, they called us back or so, and they said, hey, we used what data you gave us, and we've run our models, and we want to share the results with you. So a colleague of mine said, hey, why don't you invite them to come up to Brooklyn and present the information to the community? So we did that, and they came up to a high school in Greenpoint, and we had a couple of meetings. And at the first meeting, the EPA scientists were sitting up in front of the room like I am here, and the audience was listening, and they were describing how innovative and progressive their new approach to cumulative impacts was. And in fact, this debate is still going on sort of cumulative risk analysis. And they said, you know, we've looked at things like air pollution and air toxics and water pollution and what's getting into your body, and lead paint was a big issue in this neighborhood, and we've even looked at your diets, and we've assessed what you're eating and what the hazards are from your diet. But they said, but you know what, we've done our homework, and we didn't know exactly what you guys in Brooklyn were eating, so we used something from a survey called the National Health and Nutrition Examination Survey, which is a telephone survey that's done, I think, annually, which categorizes something called the Northeast Urban Diet, which is, I'm not making this up, this is a diet for if you live in the northeastern part of the United States in a city, you eat something different than if you live in the southwestern part of the United States. And they apparently have good evidence to back this up. So they said, hey, we don't know what you eat here in Brooklyn, but we got this Northeast Urban Diet. You know, so people in the audience started looking around and said, you know, default Northeast Urban Diet, this is Brooklyn, hey, this isn't us. And then people started to raise their hand and say, not only that, but we've got folks in this community who are eating fish from the East River. The East River, you can hardly see it, is right here, adjacent to this community. And they're living off a subsistence diet of East River fish. And a number of people in the audience said this. EPA scientists and folks looked at themselves and said, yeah, we know people fish for recreation. They do that all over the place in cities all over the country. And people said, no, people are actually eating a subsistence diet of fish right here in Brooklyn. And they looked around and they said, yeah, we know people eat fish for recreation in cities. And this went back and forth for a number of times until people really made a strong case and said, hey, we'll bring you out to the piers and show you, you can meet and talk to some of these folks. And that's exactly what we did. But when we got, and this was a few weeks later, we got out to the piers, and the EPA guys got out of their van and we started walking over to the anglers who were fishing along the East River. in the shadow of the Williamsburg Bridge. And you know, they turned around and they saw us coming, and they put their gear down and started walking the other way. And it became pretty apparent pretty quickly that the EPA folks who wanted to hear about and learn about something of this potentially hazardous practice in this neighborhood weren't going to be able to get accurate and honest information from locals because they probably weren't going to be trusted, or immigrants may not have felt comfortable talking to these outsiders. So after, again, a series of meetings, we sat down with the EPA and designed a community survey that community members and some anglers themselves would administer, in addition to holding focus groups and some meetings with local people about sort of not just what were they doing, but how much were they eating of these fish, and why were they doing it. So we conducted this survey, and we found that the average angler in Brooklyn in this neighborhood caught 57 fish per week and fed their families almost 10 fish. We actually took fish samples from these folks and tested them for metals and other toxics. We found that many of the fish were bottom-feeding fish in the toxic sediment. And we gave this sort of toxicity data and the consumption data and the rest of it, which broken down by population, ethnicity, age, sex, gender. And EPA ran sort of plugged us into a traditional risk assessment and generated a 1 in 10,000 lifetime cancer risk for adult subsistence anglers. Where are my environmental health people in the audience? Anybody know? What would be a safe safe for EPA finding? Anybody?
1 in a million?
1 in a million, thank you, yes. So 1 in 10,000 was looked to be a significant hazard, even in the more traditional sort of risk analysis approach. And importantly, in this idea of sort of co-producing expertise, the lack of data didn't equal a lack of harm in this place. But there was more to this story that we found that I think sort of gets to the idea of thinking relationally about places and the importance of governance. That when we interviewed people and we heard that from them in focus groups, that they said things like when they ate fish, it reminded them of who they were and where they came from. Many of these folks were Caribbean immigrants, and sort of the immigration experience was a displacing dynamic, and this practice sort of was something that was comforting. We heard a lot from people that there was a regular trade-off between paying for rent and buying food, which is not uncommon in low-income communities. And the practice of catching fish and feeding that to their families made that trade-off less challenging. And in fact, this was a rapidly gentrifying neighborhood. Rents were increasing, and this was happening more and more. Many of the low-income folks were being driven out of where they were living. This was a neighborhood where I come from. This is a neighborhood in Brooklyn. This was 5 square miles, 160,000 people. Not one supermarket, not one full-service supermarket. Really just these kind of bodegas, these corner stores that serve specific ethnic populations. This was so some of these and other findings led us to, in a coalition, again, this multi-ethnic coalition, to begin to intervene before we had the results back from EPA for their larger study. We did traditional environmental enforcement by trying to target people who were dumping illegally into the East River and tributaries. We identified sites for community gardens and built community gardens and attracted a new farmers market to the neighborhood. We began a rezoning process to encourage supermarkets to move into the neighborhood. And we began a planning process to build supportive housing. And supportive housing, for those who are not familiar with this in planning or other fields, is housing that has social services either built right into the physical structure on the ground floor, for example, or is tightly knitted and linked to social services. They could be a health clinic, they could be job training, it could be services for people recently released from prison, and all of those were needs that we heard from people in this neighborhood. So the idea of supportive housing that linked affordability with social services was something that we initiated and eventually got built, one, and planned for a couple of other sites in this community. Let me give you a second example of this work to bring you to the other coast, to San Francisco. where also lots of pressure for development, high housing prices, and the largest redevelopment or development plan in the city, currently still the largest residential mixed-use development plan in the city, called the Rincon Hill Plan, which is right near downtown San Francisco and right over the Bay Bridge. Called for a series of high-rise luxury housing with some commercial, mostly retail on the ground floor, and was billed as smart growth and infill development. And planners and architects embraced this as, you know, green and, you know, against sprawl and you know, a really innovative, environmentally progressive project. And in many ways, it was compared to some other things that were being proposed. But local residents, particularly in the South of Market neighborhood, which was a transitional neighborhood, largely Asian Pacific Islander immigrants, and also close to the Mission District, were concerned that this project was not going to have any community benefits, or many community benefits, but was going to attract 8,000 to 10,000 new families in the downtown area. That it wouldn't meet local housing needs for existing residents. It was going to be high-end market rate housing, and had no plan to provide any new parks or new schools. San Francisco has an inclusionary zoning law which says if you build market rate housing, a certain percentage of that has to be affordable. What's in that provision is it doesn't say where you have to build that affordable housing. So about 12, it's often 12%, I think now it's up to 17% has to be affordable. This plan was going to build their affordable housing in a neighborhood called Bayview Hunters Point, which is largely low-income public housing, a community of color, literally miles away from this optimal downtown site. And for all of those reasons, the lack of infrastructure and the lack of affordable housing on site, community groups protested and wanted changes to this site plan. They approached the planning department with their own plan, and the planning department said, yeah, that sounds like an interesting set of concerns, but we've done the environmental review, and this plan looks to be green and smart infill development. They approached the health department and said, can you help us? The health department had already had a history of doing some work around this thing called health impact assessment, which was really looking at non-health specific policies, sometimes housing or land use plans, and taking a health lens to them, putting health analyses into them. And they saw this as an opportunity to engage again in land use planning on the biggest redevelopment plan in the city at the time. So they partnered with community groups and invited the planning department into this process. The planning department said, well, we've got other things to do, but go ahead, and it sounds interesting. Maybe we'll hear what you have to say when you're done. And they did a health impact assessment of this project. They documented some of these things up here and used sort of secondary data from the literature to make the connections to health of lack of infrastructure or parks, of school overcrowding, and of racial residential segregation. But they also documented the positive things that this project would bring: health benefits from affordable housing, even though it's not on site, and some new improvements to street layout and design in an area that was really abandoned industrial close to waterfront property. They documented things like the adverse health impacts from noise, increases in pedestrian injuries at intersections, and the lack of parks, as I said. Generated maps and data, such as this one on the bottom right, showing sort of the availability of green open space. They did a whole study of pedestrian injuries at different intersections and presented this to the planning department and wrote a comment letter as part of the environmental review. The planning department said, again, that sounds interesting, but we've already approved this project through the environmental impact assessment process, and it's approved to go ahead. So community organizations who were now armed with this information went to the Board of Supervisors, sort of the city council in San Francisco, and also presented these findings and raised the profile of the health impacts of this project. And the Board of Supervisors actually, after a series of meetings and listening to different health information, passed a new resolution requiring that the developer pay a development impact fee of $25 per square foot, which was significant in any place, but also in this project, which was estimated to raise about $50 million for a community benefit fund to address some of these adverse health impacts. And that was a key outcome from this process. But part of that community fund, they legislated something called the Community Stabilization Council, which is tied into the Mayor's Office of Economic Development and has 8 elected officials from the community to oversee this money and to do sort of community health planning with these funds. So the combination of the impact fee with the sort of governance structure of this responsive both to community and the larger public through the mayor's office council to manage this money was an innovation of this community benefit agreement that has focused to date on doing improvements to infrastructure and providing a stabilization fund for people that are displaced from rising housing costs in this neighborhood. This is just some of the data that they presented. One of the major concerns was pedestrian injuries. And here's where I think planners and designers can really partner in important ways with public health people and transportation folks to show things like pedestrian injuries at intersections and document they documented the differences across different neighborhoods in San Francisco and showed where this development was going to be in the south of Market area. Already had high levels of pedestrian injuries and was sort of an unsafe pedestrian environment. And this was a major concern from this development. And one of the things, in addition to the parks and school overcrowding, that really swayed the city council, the supervisors, to demand the development impact fee. They also, by the way, changed the affordable housing law to ensure that people in the future can't build the affordable housing off-site. It now has to be built on-site. Last example, also from San Francisco, the use of this health impact assessment process had been going sort of piecemeal project by project. The Rincon Hill development, a couple of other housing projects, some urban policies. The criticism was that it's too piecemeal, it's sort of ad hoc. How can you institutionalize this in a more regular way? A major rezoning was planned for the eastern neighborhoods of San Francisco. It's actually now gone ahead. And the health department and the planning department partnered to use run a public health impact assessment process to analyze the positive and negative health impacts from this rezoning. They started by asking the stakeholders, it was about almost 30 different public and nonprofit and private sector organizations attended, what makes a healthy place? Instead of starting with what are the negative impacts or what are the problems here, they started with what makes this place or your community healthy in a visioning process, much like we would do in a community charrette, for example. They identified community health objectives and quantified and quantifiable and qualitative indicators to attach to each one of these objectives. They did new research, and actually most of the work was bringing together disparate data sets that were already available in the city, but just at different city agencies or in nonprofit or research institutions, and bringing it all together in one place. And linking things like land use change with health outcome data, with transportation information and air quality and the rest. But that really provided a rich set of data in one new place and developed a set of recommendations based on these analyses and their original vision of what makes this place a healthy city. One of the major outcomes to come out of this process is something called the Healthy Development Measurement Tool, which is available online. And the idea was that there's an online process, a set of indicators with development targets attached to them that anybody in any part of the US or really any part of the world could use and adapt to their place to link development and urban planning with public health. This particular one has over 100 different indicators. It asks, first of all, what are your baseline conditions in your place? And sometimes that's harder to answer than you might expect. Does the policy or plan or project promote healthy conditions in this area? And what are the range of healthy development alternatives? What's important, I think, about this process and this product, as opposed to many other indicator processes, is that it has a set of outcome alternatives, not just measuring are we getting better or worse in this place, but what might we do to intervene to get better or worse. And this is sort of the structure of the healthy development measurement tool. It has a healthy city element. In this case, it's a broad thing of public infrastructure. It has a community health objective attached to it. The one in this case is assure access to daily goods and service needs, including financial services and healthy food. Linked to that and online, you get a health-based rationale. And this gives you a link to the public health literature to support this as a claim for a healthy objective. It then has a measurable indicator attached to that objective. So what are the proportion of households within a half mile of a full-service grocery store? Again, you could have a half mile or a quarter mile of a bank or other essential services. It has baseline data for the entire city of San Francisco, and you can break this down by neighborhood. It has this information mapped and also sort of a tabular data behind it if you wanted to do analysis. And then again, it has this idea of a development target. If you're looking in this area, what ought to be the kinds of outcomes that you would strive for to achieve this goal of this community health objective. And I think importantly, this was a really interesting tool, but it's now being used regularly by the city's planning department to screen area and local plans and rezoning plans and many development decisions. And it is really acting as an ongoing monitoring and accountability tool in ways that we actually didn't expect when we started this process in 2004 in response to criticism that we were just doing sort of ad hoc planning with health. Some examples of how this work is now spun into the larger Bay Area, and I would argue nationally. In the city of Richmond, California, across the bay from San Francisco, they've just completed and are now approving the first health policy element within their general plan. So by state law in California, every city has to do a general plan, and they're also required to do a housing element, which is how are they going to meet the housing needs in the next 10 to 20 years for their population and population growth. This city has now done a health plan, a health policy. It's actually focused on health equity as part of their general plan update. And there's 3 or 4 other cities now in California and counties that are doing the same thing, working right now in the city of San Jose on the same thing. The Robert Wood Johnson Foundation just came out with a report called Building a Healthier America. I don't know if any of you saw this just recently in the last month or so. One of the top recommendations is to address healthy places and make places more healthy through linking urban planning and public health. And I think really importantly for me, something called the Healthy Places Act was floated by a particular senator in 2006 and 2007, and that senator was Barack Obama, and co-sponsored by Hillary Clinton and John Kerry, among others. And as part of that Healthy Places Act, which we actually drafted a California Healthy Places Act, which made it all the way to the governor's office but was not signed last year because of budget issues. But we really just copied Obama's bill. And what he wrote was really 4 major things for the federal government to take the lead on. One is to link and explicitly link urban planning and public health and transportation and other spatial work through interagency coordination. Also specifically address these social and environmental determinants of health, things that I mentioned at the beginning of the talk. Develop integrated place-based models for addressing the sort of health disparities by place and by location. And they explicitly say, differences within inner cities, inner suburbs, and outer suburbs. And finally, the final piece of the Healthy Places Act is to institutionalize this process of health impact assessment in the Centers for Disease Control, Department of Health and Human Services, and to spread to many other health agencies that do relevant work mentioned up here, urban planning, HUD, and transportation, and the rest. So I'm optimistic that maybe this will get some new traction now that Obama is president. So let me just close by saying that policies which have improved average population health have had little impact on redressing spatial inequalities in health. We need a new strategy. We need urban planners We need people who work locally but can think regionally and nationally to weigh in on health policy and healthy planning. We need to incorporate health equity analyses into all non-health specific urban policies and project reviews. We currently don't do that. Health impact assessment is one, but not the only way to think about doing that. And as designers and planners and other folks who work at the community or spatial scale, we need to think about these challenges of governance, of generating new healthy policy and practice innovations, bringing together multiple levels and sectors of government, building new expert citizen networks to generate the evidence and to provide the policy support for some of this work, to think about this relational idea of place, the interactions of place features, and I think importantly to recognize that we're going to get this stuff wrong more than we're going to get it right. We're going to make mistakes as we go, but we don't have any more time to wait to intervene. So we need to design really robust systems for monitoring and tracking of urban health equity. There's a major national initiative for environmental public health tracking in every major city in the United States, driven by the Centers for Disease Control. We need to do this add the social determinants of health to this work and look by neighborhood, city, and region to ensure that what we're doing is working and working for populations and places that need it the most. So I'll stop there.